My disclosure information, which is shrinking, is here. And I'll start with this cartoon of the carotid bifurcation, the ultrasound probe being on the skin. Carotid's a good target. It's the first one we sort of started using when we started looking at intimal medial thickness back in the mid-1980s after it was first described by an Italian group of investigators in Milan. And as you look at this schematic, what you see is the common carotid, the bulb, and the internal carotid artery. Now, one of the very first questions that gets asked is, well, what should we be looking at? Should we be looking at the common, the bulb, or the internal, or should we be looking at all of them lumped together in some, Z-score or what have you? And it's often stated, since investigators make different, and should we be looking at the near wall, or the near wall and the far wall, or just the far wall? And investigators over time have chosen different approaches. And so one of the criticisms of the carotid artery being used the carotid intimal medial thickness being used in any venue is well, they don't have a standard protocol, like say with coronary calcium, which is pretty straightforward, and at least so far, although I suspect it will become more complex with time, just as the carotid artery has. And so it isn't just a simple number that you throw out. You have to always define what your protocol was, and that's a criticism, a weakness, supposedly, but those of us who have been in this field for a long time have come to recognize that the carotid artery is in fact a very complex artery, and there are different messages in the different segments, and you just can't generalize about the carotid bifurcation. The common is slightly different association with risk factors than the bulb and the internal. For instance, diabetes and hypertension relate more strongly to the common. Other risk factors more strongly to the bifurcation region. Events, outcomes relate to different segments. Stroke relates a little more strongly to the common, whereas heart attacks relate a little bit more to a little bit higher up in the vessel. And so as you design a study and you're looking at power calculations, particularly in terms of risk, it really doesn't much matter where you look, and it doesn't much matter how you measure. It's really easy. I can eyeball a carotid anywhere and pretty much tell you what classification someone falls into because I've looked at so many of them. And so for risk assessment for an individual, for one point in time, it's pretty simple. But once you start wanting to look at progression and change over time, it gets much more complicated, much more difficult, and you have to put a lot of attention into the protocol and deciding what the question is and how that question relates to the specific segment of the artery that you're looking at. So I just want to throw that out as a caution. Now, this is a slide that shows the carotid intimal medial thickness, thin at the top, thicker at the bottom, in the distal common carotid. And just looking at this, you don't need to measure anything. You can see there's a difference between the two. The person at the top might be in the low risk category, the person in the middle might be in the moderate risk category. And in terms of whether you want to treat or not, your eyeball usually is sufficient. This shows measurement of the different layers of the carotid artery, again in the common. So the near wall is at the top and the far wall is at the bottom. And then the different lines in color here show you the intimal medial thickness. So the black hole in the middle is the lumen, and then at the bottom you're seeing the green line showing the far wall, first echo, and then the second, the blue line. And the distance from the green to the blue there represents the intimal medial thickness of the far wall. Now, in our laboratory, another question that comes up is, well, should I use automated edge detection to measure this, or should I do it by hand? Which is better? Which is more predictive? People literally almost attack each other in podiums on this particular topic. There's the automated edge detection crowd. Usually the fellow arguing the strongest has actually developed his own algorithm, and so he's vociferous that that's the way to go. The hand group is, another crowd. In our lab, we've measured an awful lot of these. We've had 2 edge detectors over the years. One was developed by my colleague Joe Pollack, which we've used, and another one is we purchased. We've tried both. Joe is actually presenting a paper, Dr. Pollack is presenting a paper at this session in the American Heart that says that for the common carotid, the automated and the hand do just about the same. We tend to do it hand-drawn in most of our studies for two reasons. One is we almost always look at the bulb and the internal as well in our studies, which for the most part are big epidemiology studies. And once you start moving up into that area, automated edge detectors just don't work well. And the second reason is, frankly, that when we have used automated edge detectors in some big studies, epi studies, we've gotten in trouble. So we tend in our laboratory to focus on the on using a handheld. But given a skilled, given a good protocol and a lab comfortable with the automated edge detector, it probably works just as well, at least for the far wall of the common carotid. Now, these are just some of the major epidemiologic studies linking carotid intimal medial thickness and incident CVD endpoints. And one of the things about the carotid is that it flew under the radar scope for a long time. That is, unlike with some other techniques, people didn't, when it came out, it wasn't a gee whiz phenomena. And there was but on the other hand, at the NIH and in the European community, there was a lot of interest in it as the first imaging study that could look directly at atherosclerosis. And so there was, in fact, a 10-year period when we were able to do a lot of epi studies, big epi studies, that looked at measurements and then related them to outcomes. And this is just a summary of them, or at least some of them. The one that Dr. Pollack and I were involved with, the cardiovascular heart study, but also Mikhail Botts and others, the Rotterdam study, and then ARIC was another one that where the core laboratory was at Wake Forest. And finally, more recently, there's been a study coming out of Europe, the carotid atherosclerosis study. And when you look at these in toto, this, by the way, is a slide from that New England Journal paper, Kaplan-Meier curve, that simply shows that if you have a thin wall at baseline and no risk factors and you wait 7 years, you tend to do quite well. You have a 4% likelihood of a CVD event, whereas if you fall into the thickest quintile at baseline with no prior history of atherosclerosis and you wait 7 years, you have about a 26% likelihood of an event. So this is where the IMT is simply used as the screening test. It doesn't take into account any of the other risk factors. Sort of what our previous speaker was talking about. This is just using a test to look at the level of atherosclerosis. It was in an elderly population, 62 years old, I think, at enrollment on average, or actually older than that. And so we had plenty of events in this particular study. It showed that of all the risk factors that we measured in the cardiovascular health study with a population of about 6,000 subjects, carotid intimal medial thickness was more predictive than anything, including age even. So it proved that it was a very effective test in terms of prediction of disease, of outcomes over time. So this is a summation of all the major studies assessing the value of carotid intimal medial thickness and assessing individual risk. I'm not going to read it off to you. They're remarkably consistent, and they show various levels of, using relative risk. All of them bump it up and move the patients into, help you better categorize patients using imaging, which is sort of the theme of this study, of this particular conference. Now, just of the two imaging tests that the Texas legislature is supportive of, you have to ask, well, which is the better test? This has been looked at in the MESA study, multi-ethnic study of atherosclerosis, which published in the Archives of Internal Medicine in 2008. And this is a large study. Again, our laboratory was the core lab for the carotid intimal medial thickness measurement, and then the coronary artery scoring was done elsewhere. And this shows the hazard ratios for related to outcomes in MESA. And this was a slightly younger population, or a younger population than we saw in the cardiovascular health study. I forget how long we waited. It was about 4 years. Some of the revascularization was one of the outcomes included in order to get the statistical power, which I think weakens the study a little bit. But nevertheless, as time goes on, we'll get more and more data. But what it did show very clearly is that coronary calcium is more predictive of outcomes than carotid intimal medial thickness. And you can see the numbers up there. And that I think is correct. I mean, I'm a CIMT guy, but data is data. And in MESA, we've seen plenty of other data out of MESA including relating it to all sorts of other risk factors and not just events, well, more events since this paper was published, but a lot of other things. And consistently, calcium is more predictive, more strongly related. So coronary calcium, when present, and about half the subjects in MESA didn't have any coronary calcium. So when you're dealing with a score of 0, you're dealing with an unknown, but still it is a good predictor. And so that, I think MESA was designed specifically for this purpose. How predictive was coronary calcium? And the gold standard that was used in the MESA study, and this is an NIH-funded study, multi-center, prospective, etc., showed that coronary calcium came out as the clear winner. At least in this age group. And the reason why I say at least in this age group is this is another study. It's the only other big study I know of. This used CHS data, and it was done. Ann Newman at the University of Pittsburgh published this paper in the American Journal of Cardiology, also in 2008. And what she looked at was simply death and how long people are alive. Based on, again, Kaplan-Meier curves here, survival curves, using on the one side IMT and on the other side calcium, and in fact the data was exactly the same. So at least in the older population, 65 or older at enrollment, when you studied them, that group, there was no difference between CIMT and coronary calcium. Now, one reason may be, and I haven't really looked into this, is that in CHS, we look, well, this is death, so actually that generalization doesn't even hold up. So again, I don't think it's totally clear that calcium is a better predictor in all age groups, but in the younger age group it is, if present. In the older age group, they may be equal. And there'll be more studies and more data over time that will help sort of sort all this out. I did want to take just a moment to talk about the IMT definition of plaque, because you often get the argument is, in fact, I heard it again last night, is intimal medial thickness really atherosclerosis, or is it something else? Well, it certainly acts like atherosclerosis, as we just saw from all the data that I showed you. But these are the definitions. But what about plaque? Because people get caught up in plaque, and they also get caught up in, if plaque is present, do you include it in the IMT measurement, yes or no, or do you measure plaque separately? In our laboratory, we've always included, if plaque is present, we always include it in our measurement of IMT. To me, this seems to be common sense. It's not something separate. I mean, plaque exists in the intimal medial. That's where it starts. And so we include it in our measurement, but others don't. So what is plaque? Well, there's two definitions. Sometimes you just see uniform thickening of the vessel, and so there's been a search to say, well, if you see a very thick wall, is that plaque? And I think the field has sort of settled down and said, well, if there's a thickness of 1.5 millimeters or greater, that should constitute plaque. That came out of the Mannheim Consensus Conference that was held some years ago that I attended. The other thing is, the definition that came out of that was a focal structure that encroaches into the arterial lumen of at least 0.5 millimeters, or 50% of the surrounding IMT value. So two definitions of carotid plaque for those of you who might be interested. This is a slide that Greg Evans at Wake Forest prepared and gave me. I'm not going to talk a lot about progression tonight. That's not the focus of tonight's conference. But this just shows a group of different studies that did look at progression, and it shows you what the thickness, how much change were they able to measure over time, and it also shows you the standard deviation of the measurement. And one other fact that isn't on the slide that I want to throw out is that the axial resolution of an ultrasound machine is about 0.1 millimeters, and the average thickness of someone with a normal carotid intimal medial thickness is about 0.6 millimeters. And as the vessel wall thickens, the standard deviation of the error of the measurement also increases. So the kind of change that you tend to see in a population, if you're trying to track change over time, is in the range of about 0.01 millimeters per year, or even less. So you're looking at a wall that may be, let's say if the patient's diseased is 0.8 millimeters, you're trying to find a change of 0.008 or 0.004 over a year with a standard error of 0.04 with a machine that has an axial resolution of 0.1. And you have labs that, with even in a lab that is where you have terrific training and everyone knows what they're doing and exact uniform, there is just no way, in my opinion, that you can track change in individuals over any kind of reasonably short period of time. And that comes up a lot. And I'm very dismissive of it. There are clinicians out there who say, oh, I track my patients, I have them come back every year, every 2 years, and I look for change, and I look to see how the effect of the treatment is. And I just say flat out, you can't do it. It exists in your mind. It doesn't exist in reality. The physics are against you. Reality is against you. Any study that looks for change in a trial where they're looking at over time, it takes a minimum for, if you're doing a 2-arm study, it takes anywhere from 600 to 800 subjects, 300 to 400 in each arm, with very exacting technique and at least a minimum of 2 years before you can be really sure the change you're measuring is really there. So to try and bring this down to the individual level for carotid IMT is, you just can't do it. Now, I want to establish my bona fides tonight, if I said that right. Bona fides or bona fides, no one's ever informed me which way it should be pronounced. This is our laboratory now in Boston at Tufts. Myself and Dr. Joseph Pollack was sitting back there and who's going to be presenting no fewer than five papers at this meeting of the American Heart on work that's come out of this laboratory. This just sums up what we've done. So we've been the core lab for cardiovascular health study, IRIS, EDICT, Framingham Heart Study, MESA, and Cardia. These are just, and a lot more, frankly, but just on this slide alone, there are over roughly 25,000 subjects that are in our database from these different studies, measured at least at one point in time. And all of these on the slide, I think, except for Cardia at the bottom, have been measured at least twice. So we've had progression data in most of them. So we have progression data. We've done well over 50,000 studies for progression data and 24,000, all related to the full battery of risk factors and all related to outcomes. So we have a tremendous amount of data. We've been mining it and looking at it. And as I mentioned, Joe is starting to now publish it in a massive sort of way, or Joe and myself, but Joe does most of the work. And so I think we can speak credibly when I make generalizations, because I'm going to make some generalizations now. I'm going to say, it's not time to define them all and defend them all, but I would say flat out that plaque characterization is of no value in managing individual patients. We've done plaque characterization on every single one of those patients or those subjects, participants that you saw in the prior slide, and we have reported on it, and we've looked at it again and again. And there's some associations with plaque characterization by ultrasound, but they're not great, and they don't blow you away. And when you come down to the individual, when someone talks about a hot plaque or a cold plaque or a stable plaque or an unstable plaque or an ulcerated plaque in individual subjects, I don't accept it. I say you can't do it. I also say that sequential ultrasound examinations are of no value in assessing therapeutic response in individuals. I said that once, I'm saying it again. Finally, total plaque area or plaque volume or what have you, measurements are of unclear value to me. David Spence has been publishing on these for years. I've visited his lab. In theory, it's a better way of measuring IMT. I would accept that. It's just that the technique has to be worked out, it has to be standardized, and then it has to be validated in large prospective multi-center studies linked to outcomes. We don't have that. When we have that, it may turn out that total plaque area or volume is actually a better way to measure IMT. And once we get there, maybe we'll do better than coronary calcium in the younger population. But at the moment, I'll just make that generalizations. Now, are there subsets of the population? This comes back to what tonight's talk or what tonight's panel is about. Are there subsets of the population where the value added by bioimaging could be shown to be cost effective? And the answer is yes. And I think the question is how much, one of the things I'm concerned about with SHAPE is there an overreaching? And I'll come back to that point in a moment. But there's certainly a portion of the population that we definitely should be doing bioimaging on in order to assess risk and treatment. It's just that, what is that population? And is it everyone, or is it some subset? And if so, what subset? I'm not going to read the slide. You can read it for yourself as I've been talking. It just makes the general point that the Framingham score isn't perfect, but you already heard that. Now, there have been recommendations for screening with bioimaging, and again, I'm not going to go through each one of these, but these are all NIH-sponsored, I think. Well, the first one's the American Heart, Preventive 5, but the other two I know were both NIH. And so there's been sort of a movement by experts to more and more encourage the use of bioimaging to assess risk. And then most recently, this is a consensus statement from the American Society of Echocardiography, CIMT Task Force. I show this not because they recommend. I mean, these guys, after all, use ultrasound, so I'm not surprised that they're supportive of its screening. But I like their protocol. It's a simple protocol. And if you are doing screening, I think this isn't a bad way to go about it. And basically what they say to do is recognizing that some labs are very good and some labs are less good, and people approach this somewhat differently. That look only, for your measurements, only look at the common carotid far wall, which is far and away the easiest place to measure. And then do a quick scan looking for focal plaque, because if you see focal plaque, and I've already defined it for you, if you see focal plaque, that's bad news. That immediately throws you into the high-risk category by at least IMT criteria. And then finally, I'm very happy that at the bottom of their recommendations, they said serial studies of CIMT to address progression or regression are not recommended. So they're supportive of my statement. But I think this is a simple protocol, an easy protocol, and I think any lab is capable of carrying it out to assess risk in individual patients. Now, this is a schematic put together by Nathan Wong. I'm not going to explain it to you. It's just because I don't quite understand it myself. But the point of it all is all the action takes place below that 20% line in that middle box. And basically what you're trying to do, at least by this scheme, is you're trying to take people in the intermediate risk category by Framingham, but the low intermediate risk, and bump them up into the high intermediate risk, and you're using the imaging test to make that push to move them up. And I think that's valid. That is the point. If they're at high risk, you're going to be treating them anyway to the maximum by Framingham. And if they're at low risk, you're not going to be. I mean, there are some patients at low risk that will have a positive bioimaging scan or screen and should be treated aggressively. The question is how many and how much money are you going to have to spend to find them. I don't think that's a very rich area to go hunting around in. So it's the middle part of this screen that we're focusing on, and then the population at the sort of the bottom part of it moving up into the higher part above that dotted line. It comes back to the same question. How many patients are there? It's a lot. I think 23 million or something like that. What's the incidence of the disease? What's the cost of the test? What's the impact of the therapy? And these are all issues that you have to, I'm not going to try and address any of those questions tonight. There just isn't time. But I think all of that has to be considered before you say, now I'm going to go ahead and doing an imaging test. I think you need to go with an enriched population, and you have to figure out how to do that. So this is just from the first SHAPE guideline. This is sort of, you've already heard this also, that what they end up doing is they recommend non-invasive screening for all symptomatic men 45 to 75 and asymptomatic women 55 to 75, except those at very low risk, using either CT or ultrasound. And this is their view of the world, which we've already seen. Now, I don't agree with this, but I don't agree that we start there and then work down. But that's not to throw the baby out entirely. There is a use for bioimaging. The question is where. Now, the other thing is, I gave a talk on this topic about a year ago in Seattle, and the day before I gave my talk, USA Today came out with a story about how let the cholesterol fight begin today. The American Academy of Pediatrics, or some national organization, have recommended starting to treat children very aggressively with statins at risk. And these are just some of the quotes about treating people young. I've always felt that we should be focusing on younger and younger. You know, when you start, the whole idea of disease prevention is prevention rather than treatment. I mean, you're much better off preventing a disease than treating a disease. By the time we can see it with bioimaging, they have the disease. And now we're treating the disease. We're not preventing the disease. So my focus has always been, I've always encouraged audiences when I've spoken to start thinking in terms of younger and younger intervention. Start identifying people. Yet we have powerful tools now, powerful tools that don't have a lot of side effects, and we should start looking earlier and earlier. Another point is, and I think Dr. Pollack may be presenting a paper on this, maybe not, but certainly he'll be writing it at some point, is that CIMT correlates better with previously measured risk factors than with those measured concurrently. And in our EPI studies, we're able to demonstrate this. So, in other words, stuff that you have going on younger in life has more impact than stuff that's going on as you get older and is concurrent. So, we need to start looking at younger populations. And then you say, well, what about the safety side? Now, this is a slide that was given to John Castelline, showed this at a meeting recently in Boston, and it sort of struck me. I was sort of amazed by it, and I asked him for a copy, which he did. It's not in your folder because it's his slide and I didn't want to share it. But basically, the point he was making is that aspirin is a lot riskier to take than statins. And these are the numbers he showed there. You can read them. It's pretty self-evident. Statins are a pretty safe drug. Now, I don't know they're quite as safe as is shown here. I happen to be discussing this with a couple of lipidologist friends of mine, and they say they see a lot of people have myositis in their clinics. That's a skewed population. But still, the statins are a pretty safe drug. And so the question is, how early in life should we be treating patients? And then how early do we identify what the risk factors that we're treating? You can't put it in the water. That's something people have suggested at multiple meetings. One of the reasons why is that you can't give it to pregnant women for reasons tied to the fetus, but you can certainly start thinking about treating people earlier in life. Now, what about the payers? We heard a little bit about the state of Texas saying you should pay. They're about the only ones so far who have said that. Most payers have declared CIMT experimental and not medically indicated. I don't agree with that, but for Medicare, it's under an investigational code, and so it's not usually reimbursed. And the usual rationale is that there's no convincing studies linking CIMT measurement to improve clinical outcomes, so you don't get paid for it. So I'm going to wrap up now in conclusion, and I'm going to start coming back to some generalizations. I'm going to say, in conclusion, A, I would not screen patients over 65 years of age. Now, I haven't even talked about that, and I'm really talking about men, not women, because IMT varies with gender and with ethnicity, a lot of different things, so that it's a complicated topic. But still, you have to look at, well, if you identify someone without late in life, 65, unfortunately for me, is because I'm up there now, is late in life, but you have to look at how many years of treatment they're going to have, and so on and so forth, whether they'll have a decent outcome. So there's some upper limit on the age where you should be screening someone. Whether it's 65 or not, or whether it's 70 or 100 or 50, it's a number that the data will give you. You can just look at it and say, well, what's the expected additional years of life I can have for treatment, and how long do I have to wait before I start seeing that versus when I'll die, and so on and so forth. So I would just throw that up there, saying there is an upper limit on when you should be screening people. I would not screen patients that are either high or low risk. I would not rank atherosclerosis test as step 1. I would wait at least 5 years before considering a repeat atherosclerosis test. I would ask how many subjects will be reclassified because of the test, how many new patients will be treated, and what will be the impact on outcomes and at what cost. And most importantly, I would focus on early life intervention for a disease that presents decades prior to diagnosis by any imaging test. Thank you.